Thank you, everybody, for joining us and for bearing with us for a few minutes here. We do have Timothy Arent with us today from the Beacon Center. Unfortunately, due to some technical glitches, you will not be able to see him, but you'll be able to hear him throughout our presentation. I'd like to welcome you all to the June 2022 session of our Erie County Workforce Collaborative Training Series. Erie County Department of Mental Health is happy to be able to offer these trainings to our dedicated providers in our community to support workforce retention and provide an opportunity for individuals from our provider community to share their expertise. Today, we're very excited to have Timothy Arent from the Beacon Center with us to talk about utilizing existential therapy and enhancing meaning, purpose in life as treatment for mental health and substance use disorders. We are still working out the details for our July session, but that will be held on Tuesday, July 26th from 12 to 1 o'clock. More info will be coming out soon, so please be on the lookout for the training notice and the registration. We'll be forwarding this information via email, or you can also go to our website, erie.gov/mental health, for announcements and registration information. All of these trainings are offered on the fourth Tuesday of the month from noon until 1 p.m. So I'd encourage you to mark your calendars and watch for notices for our future events. All of our presentations and recordings for our past offerings are posted on our website, so I'd encourage you to check those out as well. At the end of this session, we'll be asking you to complete a very brief evaluation. We hope you'll take a moment to fill this out so we can continue to improve. What I will do close to the end of this session, I'll be posting that link right in the chat, so please take a few minutes and complete that for us. This is a community collaborative, and we're always looking for volunteers to share their expertise with our providers. If you're interested in doing a 1-hour presentation or are interested in a particular topic, you can indicate that on your evaluation, or you can email Amy at amy.rockwood@erie.gov. This training will be recorded. Everyone is muted. If you have questions, please put them in the chat box. I'll be monitoring the chat throughout the presentation, and Tim will be stopping a few times throughout his presentation to answer questions. And thank you to Amy, who will be moving the slides along for us today. Again, thank you all for joining us, and I'd like to introduce Timothy Arent for his presentation on using existential therapy and enhanced meaning, purpose in life as treatment for mental health and substance abuse disorders. Thank you so much for joining us today, Tim. It's all yours.
Hi, hopefully everybody can hear me. I guess a little bit of a technical glitch, so you don't see me. The argument might be that that's for your benefit. You only have to listen to my voice and not look at my face. But thank you. Utilizing existential therapy and enhanced meaning, purpose in life as treatment for mental health and substance abuse disorders. As the ladies mentioned, my name is Timothy Arent. I am a substance abuse and comorbid mental health counselor for the Beacon Center of Amherst. Next slide, please. I would like to take a moment at the beginning. I beg your patience. I'd like to offer my thanks to a couple people. First of all, to Erie County Department of Mental Health for the opportunity to present this. I think it's a great program, and it's something that's very beneficial to practitioners who are experienced and new alike. Secondly, I would like to offer my thanks to Carolyn Grisco and Jackie West at Beacon Center. Carolyn is the clinical director and Jackie is the CEO, for allowing me the time during workday to present, and also for creating a workplace that leaves a counselor feeling accomplished and worthwhile every single day. Very much believe in what they offer to their clients, and this is in great part of it. I would also like to offer my thanks to my outstanding mentors at Medaille, Dr. Helena Boersma, Dr. Elizabeth Keenan, Dr. Don Nowak, who I see is signed in, and to Dr. Marguerite McCarty. And finally, to Dr. Patty Abbott of Duville University. Roughly about 20 years ago, Patty Abbott was the lady who introduced me to the works of Dr. Frankl and existential therapy. So very grateful for that. Next slide, please. A little history in terms of existential therapy. Although this is not a history class, I do want to just present a little bit so we have some context on what we're dealing with. Existential therapy in its current manifestation, it originated from the existential movement and philosophy. Many of us have heard in our intro to psych courses, philosophy was the mother to psychology. And this existential philosophy movement purported that each one of us is responsible for creating purpose and meaning in our own lives. It's not given to us by gods, governments, teachers, or other authorities, but instead it's very individual, very subjective to each person. Next slide, please. Again, not a presentation on philosophy, but it's important to understand that the etiology or the genesis of this modality came from the works of such seminal philosophers as Karl Jaspers, Martin Heidegger, Karl Buber, Soren Kierkegaard, and Friedrich Nietzsche. I put a quote on the very bottom, and I'd like you guys to attend to that, please. It's by Soren Kierkegaard, actually two, forgive me. First one is subjectivity being the truth, and objective uncertainty. These are two premises that started obviously in the existential movement and philosophy, but are very salient to existential therapy and its clinical application. And you will see this as the presentation progresses. Next slide, please. So why? Why in this day and age of, brief therapy, trauma-informed therapy, motivational interviewing, why look at existential therapy? Why enhance purpose and meaning? The quote, society is involved in a series of issues in terms of its existentiality, situations of violence, social differences, racism, depression, addiction, prejudice. All of these are turning humankind into walking beings with a vague or non-existent purpose that makes difficult their understanding of the world in a vital and healthy fashion. We don't have to think far back to the recent tragedy at Tops in the city of Buffalo to understand that at many times in our life, we look up at the sky, kind of put our hands out to the side and say, why? Why me? So given these existential challenges we're facing daily as a society, honestly, is there any question we must constantly attend to and revisit what our individual purpose and meaning in life is? Next slide, please. As clinicians, we need to sit back and ask ourselves, are we missing what I term the latent forest through the manifest trees? Are all these evidence-based practices, which without a question are very important and very necessary, but are they not sufficient on their own? Do they not address what I have deemed the etiology of our clients presenting issues? Are we treating symptoms, but ignoring causality? Do we have an individual coming in and presenting for depression or for alcohol use disorder, an eating disorder? And we're treating that, but ignoring what lies beneath the surface. Or even ask yourself, are you perhaps as a clinician not comfortable addressing existential issues? Next slide, please. I have a few quotes that I think really kind of hit the point. First one is by Yehuda Bacon. I really understand the meaning of suffering. It can have a meaning if it changes you for the better. And then by Viktor Frankl, one must go through their own existential despair if they are to learn how to immunize their patients against it. And then you could say versus the third, Wittgenstein stating, whereof one cannot speak, thereof one must be silent. So basically, if you don't know what you're talking about, you need to keep your mouth shut. So ask yourself, as a clinician, are you existentially competent? Have you personally dealt with suffering or existential despair? Or do you, like Wittgenstein stated, do you feel that you need to remain silent? Next slide, please. I personally believe that oftentimes we neglect what's called the spirit of the client, which existential therapy attends to in great part. We basically attend with existential therapy at what lies at the core of our clients. Existential therapy, and in particular logotherapy, which I'll be discussing momentarily, it seeks to view the client holistically. Current practitioners of existential therapy, and specifically logotherapy, have expressed a concern as to whether this neglect of clients' holistic needs may actually portend a limitation in the long-term efficacy of treatments and interventions. We need to ask if our interventions are personally meaningful to our clients. We can lay down a treatment plan. We can advise our clients, here's what you do. But if it doesn't mean anything, if it doesn't resonate to our clients, how efficacious is our treatment at that point in time? Next slide, please. Ask yourself what lies at the core of the DSM. Camus stated there is one truly serious problem, judging whether a life is worth living or not worth living. What are your clients saying? Is their life worth living? Because of traumatic experiences, sexual abuse, drug and alcohol addiction, environmental stressors, prejudice, poor modeling, so on and so on and so on. Often our clients come into our offices with learned helplessness, hopelessness, a lack of self-efficacy, reliance upon an external locus of control, feeling as if their life has been determined and there's nothing they can do about it. Obviously, lethality is a constant looming risk with our clients. And the next statement, escape to the oblivion of substance abuse, calls many of our clients. An argument can be made that all of these are but manifestations of a frustrated or a non-existent will to meaning. Essentially, our clients saying, you know what, my life's meaningless. It's less than. There's nothing there. So why shouldn't I drink? Why shouldn't I fall into the depths of depression? Why shouldn't I be anxious? Why shouldn't I consider ending my life? There's no purpose to go on. Next slide, please. Viktor Frankl in logotherapy. There is no doubt that there are many seminal figures in existential psychology and mental health. But for the purposes of my presentation, I'm attending to Dr. Viktor Frankl and his third Viennese School of Psychotherapy. It's more commonly referred to as logotherapy. Logotherapy in Greek, basically healing through the discovery of meaning. Frankl answered this to his two predecessors, Freud and Adler, who talked about will to pleasure and will to power. Next slide, please. Freud spoke about a will to pleasure. And if we think about many of our substance abuse disorder clients, will to pleasure is right there, stating that our id is driving us to seek pleasure over pain. Immediate gratification of wants, needs, and desires. And when it's not met, anxiety and tension. Think about relapse in our clients, especially with substance abuse disorder. An individual is not attending back to that which provides the pleasure, so they start to desire it. That tension, that anxiety exists. So again, consider our substance abuse disorder clients and think about the fact that many of them actually present with either an immature or a non-existent ability to delay gratification, which lays at the core of their problem. Next slide, please. Next would be Alfred Adler, who came after Freud with will to power. He proposed this will to power as a motivating psychological force. Essentially, superiority over inferiority. Clients who seek to overcome perceived inferiority, which we see many of them manifesting with, say, body dysmorphic disorder, anxiety, depression, eating disorders, narcissistic personality disorders, can all be attributed back to this will to power and this frustrated will to meaning. Even the use of substances, could be questioned as an attempt to ameliorate problematic mood states. I don't feel powerful in my existence. I have no control. So let me exert some control via alcohol, marijuana, cocaine, what have you. Next slide, please. Then we have essentially the core of this presentation, Dr. Viktor Frankl. You'll see in the upper right-hand corner of the screen, there is a shot of his most seminal work, Man's Search for Meaning. Logotherapy is based upon three premises: the freedom of the will to meaning, and the meaning of life. We will address on all three of those as the presentation continues. But just from the beginning, I'd like you to consider the fact that each builds upon each other. They're interconnected. One feeds the other. So what can logotherapy be applied to? Be honest with you, can be applied to almost everything. There's three types of disorders primarily that it can treat. First one is neurogenic, meaning and life disorders. What's the meaning of my life? What's my purpose? It feels so empty. How do I deal with this? Logotherapy can address that. It can also deal with psychogenic, or more commonly termed like conventional or psychological neuroses, the majority of which you'll find making up your DSM. And then also somatogenic or biological neuroses, those which stem from an organic nature. Frankl's logotherapy has been empirically validated to be effective in treating substance abuse, post-traumatic stress disorder, anxiety, depression, and many other notable neuroses. You'll see examples of those shortly. Next slide, please. Ultimately, what logotherapy tries to do is heal through the discovery of personal meaning, finding individual meaning in one's existence by applying logotherapy. Frankl contends that we find our meaning as individuals three ways. And please pay attention to these because these will be revisited constantly through the session. First one will be through the work that we do. The second will be the relationships we experience. And the third will be how one chooses to face unavoidable suffering. If you think about it, this is an exceptionally powerful tool for a clinician because it's very malleable. It can change. It's subjective, which means it's very interpretive. Every client can use it. It doesn't matter if it's your 20-year-old attorney, your 40-year-old truck driver, or your 70-year-old woman who is residing in a nursing home. Every single one of these clients can be treated through logotherapy. And ultimately, what it allows us to do as clinicians is to help our clients not feel as if their problems are holes they've fallen into that they can't get out of, but essentially how they can turn their despair into triumph. Next slide, please. Why do we do this? I mean, Frankl constantly references to Friedrich Nietzsche, who stated that the people who know the why in their life can deal with any where or how. Anyone who knows what the purpose of their existence, why they get up in the morning, put their shoes on, and keep going, can deal with anything. Essentially, Frankl proposed that the clinician, by helping the client to find their own individual subjective purpose in existence, can start knocking away almost every disorder. Of note is the fact that we have to understand logotherapy is not us as clinicians telling our clients what the meaning of their life is, but it's assisting them in finding the meaning of their life. But what we are doing primarily is we're showing our clients there's meaning. And that meaning is always there in our life, no matter what the circumstances are. Whether it's terminal cancer, whether it's substance abuse, whether it's panic disorder, whether it's anxiety, whether it's gender confusion, whatever the case may be, logotherapy can help your client find their individual purpose and meaning and bolster their existence. Next slide, please. Why are we doing this? I can almost hear in the background some people saying, why am I going to do this? I'm a substance abuse counselor. I'm a mental health provider. I'm a physician, what have you. I want you to think to your own clinical environment and situations you've had when you read this quote. In former days, people frustrated in their will to meaning would probably have turned to a pastor, a priest, or a rabbi. Today, they crowd clinics and offices. The therapists then frequently find themselves in embarrassing situations, for they now are confronted with human problems rather than specific clinical problems. Folks, often we find ourselves attending to meaning in life or purpose in life disorders. Clients don't always come in and say, help me get rid of my triggers for drinking. I don't understand why I'm so anxious. A lot of time people walk in and tell us they're frustrated with their lives. Their marriage is a mess. Their kids are driving them up a wall. They hate their jobs. They're disgusted with, they're just disgusted with life. That is an existential question. And if we are going to allow our clients to walk in our doors, sit down in the chair across from us and present us with this question, well, then we have to be prepared to some extent to be able to answer this ontologically. Next slide, please. Meaning in life versus meaning in life. Visual, capital M versus lowercase m. From an existential purpose, understand meaning in life isn't universal. There isn't just one meaning in life that everybody has to get. But it's very individual, it's subjective and interpretive. It's different from me to you, to the next guy, to the next guy. It changes. It also is malleable, and it can change as time goes by. Less than a year ago, I did a very, very interesting project with Dr. Marguerite McCarty at Madai, where we talked about, growth and development. And I did a meaning in life presentation, which attended to an individual who was 25, one who was 45, and one who was 75. And after interviewing, it was amazing how much what is so salient at 25 years old means absolutely nothing at 75 years old. Is there a common thread that carries? Sure. But ultimately, as I say here, it morphs and changes. The last thing to keep in mind with meaning, there's two different types. There's super meaning, which is kind of the overarching, which is like God, spouse, children, marriage, career. But there's also little meanings that are important. I got to get up and go to work. I've got to drive the kids to their softball game. I've got to study for my test, get my GED. I've got to do one more day of sobriety. I've been clean for 59 days. I got to get to number 60. These all bring purpose in life, and neither one is more important than the other. Next slide, please. So ultimately, I'll ask you to reflect for a moment before we continue on. How many of your clients walk in your door really because of an addiction to opiates, alcohol, marijuana? Or are these manifestations of deeper latent issues? One of our empirically validated studies is going to answer that question momentarily. Is there dependence, possibly the client is seeking to fill a void with alcohol, cocaine, or marijuana? Think of it visually. Is there a void inside of them that they're trying to pour alcohol or cocaine or heroin or shopping or sex addiction or gambling addiction in to try to fill? Is there something missing from your treatment plan that might actually make a difference? And could logotherapy or utilization of some of its interventions make a difference? Ultimately, does your client suffer from an inherent lack of meaning in their daily life is a question we have to ask. Next slide, please. Logotherapy seeks to rehumanize the therapeutic process. Frankl expressed a serious concern about reducing our clients to just drives like Freud had, or behaviors or traits, or even in common day receptacles for psychopharmaceuticals. He wants us to see and find purpose in suffering and become better, more actualized versions of ourselves. Next slide, please. Next part of the presentation is empirical research proposing logotherapy in the treatment of mental health and substance abuse disorders. One can go on and on about the theory behind it, and theory is wonderful, but clinical application is ultimately the most important part. If we can't apply these theories clinically, then really what use do they have? I've selected two of many empirically validated logotherapy studies, and I've given them more of a list at the end, you'll see, but I'd like to attend to these first two because I think they give a really good overview. Next slide, please. This first study was done by Asagba and his co-author. It actually was done regarding the intervention of logotherapy into individuals suffering from substance abuse on the continent of Africa. And it's the correlation between a person's meaning orientation and their existential fulfillment. Ultimately, he spoke of utilizing this because of the trend of harmful effects, particularly with substances such as alcohol and marijuana and the use of prescription drugs, which is on the rise in developing countries. He spoke that these developing countries are not spared from this social menace due to urbanization and globalization. And he stated that it's alarming, the pattern that is increasing. Reported a significant inverse relationship between meaning in life and drug abuse. Think about this. Very best treated with self-distancing from the symptoms, modification of the attitude towards symptoms, reduction of symptoms, and orientation of the client towards meaningful activities and experiences. We're going to talk about the therapeutic interventions in the next section. Next slide, please. Logotherapy believes that a patient with a substance use disorder is in crisis. You'll notice I made bold this next statement because to me this was very salient and very eye-opening. This is because not all people using substances have a substance abuse disorder. Think about that. Think about the number of people who drink in the United States, who use marijuana, who use cocaine recreationally. Not every one of them has a substance abuse disorder. Now, granted, we can't strictly just attend to an existential issue. We understand that there are, biopsychosocial issues that can be attended to as well. However, Asagba stated that he believes the person who's using substances may resort to them as a coping mechanism, albeit an inefficient one, which leads to a further intensification of existential distress and potentially leading to despair. You're turning to an external locus of control, a substance, saying, make my life better. Well, momentarily, it does make your life better. The high does make your life better. However, once that high wears off, where are you? Either back where you started or possibly even significantly lower. The interventions he utilized in the study, just to list them, and again, we will discuss them, are modification of attitudes used together with Socratic dialogue. This is used to help the client gain some sense of control over their life or bolstering a more solid feeling of identity and purpose. There's de-reflection, or essentially helping the client to stop looking at the negative and kind of attend to the positive. And there's also the use of paradoxical intention, which we will speak about. Next slide, please. The great thing about this empirical study was he pointed out that this isn't just suitable for substance abuse disorder. This isn't something, okay, well, I can use it with my clients presenting with substance abuse, but it's useless for everything else. That's not the case. It can be used to manage a variety of crises. For examples, sexual assault, post-traumatic stress disorder, eating disorders, anger management, and grief counseling. On a very quick side note, I can tell you that I personally work with a client who presents primarily for an opiate disorder, but has suffered from extreme PTSD and anxiety, almost a panic disorder. And the implementation of some logotherapeutic interventions have made a marked improvement in how she views herself and views the world. So folks, it really does work, and it is very clinically applicable. Next slide, please. The next study is by Schulenberg et al., and it's called Logotherapy for Clinical Practice. Quote from Schulenberg, a major reason that logotherapy has something to offer mental health professionals across all different types of theoretical orientations, it has to do with the influence of meaning construct on human health and behavior. There's a growing basis for the relationship between a sense of meaning and psychological and physical well-being. So if one feels better about their existence, what Schulenberg is saying, physiologically and psychologically, there can be an upward trend. He states that meaning is associated with a range of outcomes: stable mood, less psychological distress, more proactive or sociable behavior, often evidenced in a lot of the logotherapy research that's done on inmates, favorable attitudes towards life and the self. Ultimately, he says meaning has clear significance to the human condition. And these concepts, which are emphasized in logotherapy, are of interest to mental health professionals who are striving to find ways to help their clients help themselves and are compatible with a variety of existing theoretical orientations. Again, logotherapy puts the control in our clients' hands. It's helping them find their own individual subjective purpose in life. It is not the therapist saying this is what you have to do, but it's the client saying to the therapist, you know what? This is what I think I have to do. Next slide, please. Schulenberg continues by stating that, talking about spirituality. And essentially spirituality, and we're not talking about Catholicism or Judaism or Christianity, we're speaking about meaning, values, purpose, those things that are emphasized in logotherapy. And it's becoming increasingly relevant in modern psychotherapy and medicine. I mean, ultimately, there's increasing evidence that spirituality is associated with positive health outcomes. There really isn't much question on that. We see that that is something that's even lately addressed when we're doing intakes and assessments, asking our clients if spirituality is something they would like to discuss. Logotherapy is recognized for its efficacy in the reduction of despair and unavoidable suffering. How we use paradoxical intention and de-reflection, especially for problems originating like an anticipatory anxiety. Folks that are afraid to go to work because they're afraid of what's going to happen. They're afraid, what, can I abstain or refrain from drugs? I don't know if I can do this. Worries about getting into relationships, anticipatory anxiety, and also addressing meaninglessness at some point that's characterized by the existential vacuum. We're going to speak about that in a slide or two. Left unchecked, if we leave our clients with this feeling of emptiness, it leads to disturbances from a lack of actualization of personal life meaning or from conflicts of personally meaningful values. In short, if our clients have this emptiness, this vacuum inside of them, ultimately what Schulenberg is stating is, what do they do? How do they grow? How do they live versus exist? Or do they actually start turning, instead of going left, start turning right and start conflicting with what should be their personally held meaningful values? Crime, addiction, mental health, abuse. This can be the result of existential crisis. Next slide, please. The existential vacuum, defined as basically struggling with a lack of meaning and uncertainty in your existence. It does lead to disturbances, and most common found by Schulenberg would be violations of social norms, so essentially breaking the law. Distress symptoms, so mental health issues, physical health issues, emotional health issues, physiological and psychological addictions, specifically aggression, depression, and addiction. Schulenberg, if you take the time to ever read it, he discusses his triad, which he calls SAD, the acronym SAD. Logotherapy also, which I'd like you guys to think about, is not just specifically for our clients. It can be useful when working with friends or families who are struggling in terms of how they can assist their loved ones. Think of the number of clients who present and, let's say in substance abuse addiction, they're experiencing the high and the lows, but their families are only experiencing the lows. One of the things that I thoroughly enjoy about employment at Beacon Center is we are afforded the opportunity, if necessary, we can bring a client's spouse or supportive person in for a session or two if the client requests. And logotherapy is wonderful because ultimately meaning and finding meaning in the face of unavoidable suffering. We don't just attend to the client, we attend to those supportive people who may need our help as well too. Logotherapy is applicable also with helping clients understand and accept their diagnoses, work with the professionals that are helping them, and adhere to their treatment modalities. Look, logotherapy is not going to be the cure. I am not telling you on this presentation that you have somebody with PTSD that after 3 sessions of logotherapy, they're going to be cured. However, what logotherapy does is it helps the client understand that there is meaning and purpose in their life above and beyond the diagnoses. Next slide, please. Ultimately, what Schulenberg asks us to do if we're utilizing logotherapy is see our clients as fellow human beings. Help them understand that they are unique. They're not just their diagnosis. Also, help them understand they have freedom in spite of their situation or their problem, and demonstrate to our clients what they can do to deal with their situation or their problems. He also constantly points to an issue that Frankl spoke of constantly, that the therapist can help their client understand they do have one last remaining freedom despite everything. And that's how they react in the face of unavoidable suffering or undesirable circumstances. Frankl spoke of, and I'm just paraphrasing, that the last human freedom is the ability to choose your attitude in spite of everything. Logotherapy encourages our clients to take responsibility to respond to that freedom through behaviors, experiences, or attitude changes that they think might make their life more meaningful or help address their substance abuse or their mental health. It also gives our clients dignity that oftentimes they don't feel, expecting them to be capable of human beings in spite of the limitations they have, not looking at our clients as, you poor thing, We have to take care of you. Instead, it's looking at our clients and saying, okay, this is a presenting problem. We get it. But this is nothing but a cog or a spoke in the entire wheel of your existence. And let's figure out together how you still have meaning in your life despite this presenting problem. Next slide, please. The client's encouraged to recognize the freedom that he or she has and to implement it. How do we implement it? There's 4 basic ways, and these are kind of the general steps of logotherapy. The first one, differentiation of the client from their symptoms. Helping your client understand that you're more than just a cluster of symptoms. You're not just a quote unquote addict. You are not ill. You are not anxiety. You are not depression. You are not an alcoholic. That is a symptom. And it's imperative they do not over-identify with a given diagnosis. Number 2, modify the way they think about their symptoms. Shift them away from over-focusing on these symptoms and more towards awareness of the remaining options they have, the meaning they have, the work they do, the relationships they have, and how they can face unavoidable suffering. Next slide, please. The third step would be reduction of the symptoms, which ironically actually kind of tends to happen automatically once attitudes get modified. When our clients stop seeing themselves as simply just the sum total of their symptoms, when they stop seeing themselves as nothing more than, an addict or a mental health patient, as I was told by a client yesterday, or as an alcoholic or someone who deals solely with anxiety or depression, when you put all of that to the side and you start implementing other techniques like coping skills, self-efficacy techniques, the ability to make someone feel more empowered about their life. Once more adaptive attitudes are developed in our clients feel, wow, I've got a chance to do something. I've got options. I can handle this. And this thing that felt just so unbelievably unmanageable to me, well, it's not that unmanageable. I guess I can abstain. I guess I can handle my depression. It's not as crushing as I thought it was. And then the final step is follow-up. It's maintenance of mental health through future orientation and facilitation of continued awareness of personal life meaning and goals in life. Logotherapy is a very future-oriented modality. It's understanding that, yes, the past has happened. Yes, the present is here. But as humans, we have choice, and that choice can direct where we go in the future. We have the capability to make our life in better mental health, without addiction, without improper relationships, without these stressors that are pulling at us. We can choose to move in a different direction. Next slide, please. I'd like to point out, again, because as we discussed, theory is wonderful, but clinical application and empirical validation are paramount. Support was found for the association of the 2 constructs via statistically significant negative correlation between what I deem the PIL score and the BPS score. PIL score is purpose in life, and BPS is boredom proneness scale. Higher purpose in life scores, or someone who has greater meaning, is associated with lower boredom proneness. Now, as we all also remember from Intro to Psych, correlation doesn't necessarily mean causation, but it is a step in the right direction. It shows at least if there's one, if there's an upward trend on one, there's a negative trend on the other. As one increases, one decreases. Strack also found through a series of regression analysis that empowerment is dependent on meaning in life and psychiatric symptoms. So think about it. Those clients who report, I feel more empowered. I can handle my life. I can make choices. I can direct where I go. They have less mental health, so less anxiety, less depression, less addiction, and they have greater meaning in their life. The study also offered support for the importance of meaning in life to individuals' serious mental illness, and it has to do with empowerment. Again, it may not be a cure, but it helps bolster our client to understand that they can move ahead in their life and they do have some choice. It gives, I use this with my clients in groups so many times, they're probably tired of hearing it, but rather than being a canoe just being tossed around in the water, somebody throws them some oars and they can start paddling. Are you guaranteed that you're going to get to exactly the spot on land that you want to get to? Maybe not, but you're getting pretty close. But if you've got no direction, you just end up where the water takes you. This is what Schulenberg speaks of. This is what logotherapy intends. Next slide, please. I'm not going to review these with you, but I just wanted to let you know that I did put up some other salient studies. There are literally hundreds, and they're very applicable to anything. You can use logotherapy for PTSD, for survivors of domestic violence, sexual assault, the incarcerated, new mothers. I mean, it goes on and on. But I have 4 studies here, Blodgett, Gurwood, Thompson, and Witten, that I think, if you find this interesting, might be worth your review. Next slide, please. I'd like to talk now about the crux of it, useful logotherapeutic clinical interventions for the mental health and substance abuse related practitioner. So how do I do this stuff that you're talking about? All sounds phenomenal. What do I do? Next slide. The first one, and my poor professors at Madai, I think their eyes were bleeding from constantly reading phenomenological perspective from me. But this is the core of my clinical practice. Phenomenological perspective, I'll give you the $20 definition first. Particularly applicable as practitioners are striving to improve or enhance their personal and professional, cultural, ethnic, and socioeconomic competency, as well as their ability to clinically address identification and characterization that's salient and significant to the client. The approach to mental health, phenomenological approach to mental health, it understands mental disorders as modifications of the main dimensions of life: time, space, body, selfhood. It also explains their psychopathological symptoms as expressions of dialectical modification of the proportions of certain domains of the life world or lived experiences. All right, so what does that mean in common terms? Ultimately, phenomenological perspective is this. It's the counselor driving to experience the client, how they view themselves, the world, how they think the world looks at them, how they look at the world. Ultimately, it's trying to step inside of them, look through their eyes, and experience the world through their perspective. Why I made the comment about improvement or enhancing personal and professional, cultural, ethnic, and socioeconomic competency. And in this day and age, there is such a necessary move for inclusion and cultural competency. I make you a promise, if you embrace phenomenology, if you look at each client as an individual, subjective, and you try to understand their worldview and how they believe the world views them, you will never have to worry if you're being culturally competent, inclusive. If you're paying attention to the client, because phenomenology is, I see you as a person. I don't see you as a male, as black, as white, as female. I see you as the individual you are. And I understand the identity and characteristics that you attend to, not what I attend to. It's all about the client. It's not about you as a clinician. Next slide, please. This perspective, when embraced by the client, can enhance empathy. It can reduce the clinician's potential to be seen as judgmental. How can you be judgmental when you're paying attention to solely what the client attends to? And it can enhance a client's willingness to disclose and comply with treatment. Essentially, it's improving the alliance between the client and the counselor. If your client feels, you know what, I walked away from this session, how did it go? This person really cares about me. They really listen to me. It seems to matter what I have to say. How can you ask for a better therapeutic alliance? I will recommend a little bit of reading to you folks. If you ever want to learn more about this, Martin Buber spoke of the I-thou relationship. Essentially, the I-thou relationship is meeting your client not as an expert. It's not you as, the Freudian analyst and the person's laying on your couch. It's sitting down and having a conversation with your client. It's person to person. It's nobody in a higher position. It's walking a path alongside your client, and you're no better than they are. You're there just to walk with them, point some things out, but ultimately, it's meeting them on their ground, where they are in the world at this point in time. Next slide, please. Soren Kierkegaard spoke about subjectivity being the truth and objective uncertainty. This is where phenomenology comes into with clinical application. What phenomenology reminds us? We can't treat one client as the other. And as much as we say we don't want to do that, that's a problem, because client after client after client, you see substance abuse disorder, you see anxiety, you see depression. Oh, this is how I treat that. No. What we should be doing is recognizing and celebrating their individuality, their own personal life experiences as stressors, triggers, but also as factors of resilience in their own personal mental health. You need to understand your client as an individual. Next slide, please. Second, a client-directed therapeutic alliance. There's no question, Carl Rogers is certainly not a logotherapist, but he was very important in the discovery of this. And we'll get to him in a moment. But what we commonly discuss client-centered therapy, logotherapy, and existential therapy calls for a client-directed therapeutic alliance. Ultimately, the client has to be active and participatory. The client has to be responsible to change behaviors and to find their own personal life meanings. The therapist is not there. You are not there to tell your client what to do, but to aid them in finding out what they need to do. Next slide, please. And again, as I said, probably the best descriptor for this came from Carl Rogers. I was actually given a Christmas gift by my wife and my children, which was a printout of this that I keep by me at all times. It is the client who knows what hurt. It is the client who knows what hurts, what directions to go, what problems are crucial, what experiences have been deeply buried. It began to occur to me that unless I had a need to demonstrate my own cleverness and learning, I'd do better to rely on the client for the direction of movement in the process. In short, listen to your client. Next step. The client chooses their own path, some degree of self-determination, ultimately to whatever degree they're comfortable. That will help them develop self-efficacy, freedom of choice, self-determination, internal locus of control. What a lot of our clients have given up because of substance abuse and basically feeling that their mental health is determined. They don't feel they have these options. We are instilling these options in them. Next slide, please. A focus upon choice and responsibility. I'm pushing a lot of talk about choice, which talks a lot about freedom. Freedom is very, very important. It focuses therapy upon the client's ability to choose, despite or even in face of the circumstances. Imbuing our clients with the understanding that they can make decisions in their life, they can impact the direction their life goes in, will help so much, because so many clients come in and feel that their life is out of control. They've lost control. And again, the quotation I said earlier, everything can be taken from a man but one thing, the last of human freedoms, to choose one's attitude in every given set of circumstances, to choose one's own way. It's a question of, if someone is coming in to deal with their substance abuse disorder, is it abstinence by choice or is it abstinence by force? It doesn't want to be force. It wants to be choice. And allowing our client to feel, I choose this. I choose to get over my anxiety and my depression, to deal with my symptoms, to put the bottle to the side. This empowers our client. And when they walk out of our office, they will hopefully continue those interventions that we've shown them and carry it into real life. Very easy to do inside of a closed environment, as in the therapeutic office, very difficult to do in real life. Next slide, please. I just want to make a quick point on this, because I realize we're getting close on time and I want to make sure I answer some questions. Forgive me, folks. I want to just balance freedom of choice with also responsibility for choice. One very good point that I tend to make to a lot of my clients, which I think resonates with them a lot, they always talk about the fact, well, freedom. I'm a grown man. I'm a grown woman. I can make my choices. I don't like the judge telling me what to do. I don't want my counselor telling me what to do. Who is my wife or my husband telling me how to live my life? I'm going to do what I choose. Absolutely. You have the right to do that. You have the right to take that drink. You have the right to use the marijuana. You have the right to feel depressed. You have the right to shoplift, to cheat, to do whatever it is you're presenting for. However, you're also responsible for that choice. So one cannot take one side of the coin or the other. By instilling responsibility in our clients for their choices, it also, again, imbues them with self-efficacy, internal locus of control, some control over their existence, because they start to get the fact that they're free to choose, but they're also responsible for choice. And instead of feeling like the world is moving them, they're moving themselves. Next slide, please. Socratic dialogue. Essentially, this is just a back and forth questioning situation with your clients. It's talking to your client. It's not talking at your client, but it's talking with your client, asking questions, receiving answers, and doing it in a certain way that the therapist can end up guiding the conversation towards the ultimate endpoint. Next slide, please. Paradoxical intention. This was developed, it's a good point, and I'd recommend you guys read up on it. Ultimately, Frankl talked about using humor towards a problematic mood state. Obviously, it has to be done very carefully. You have to have some experience. A very quick example was Freud had a client who worried about stuttering. He was a public speaker and came in and told Freud, he said, told Frankl, every time I stand up in front of a crowd, I start to stutter. I can't say anything. So anticipatory anxiety. Frankl gave him his homework. He said, okay, next time you go and speak, I want you to stutter worse than you've ever stuttered in your life. I want you to try to stutter. No one will be able to make a word out of what you're saying. The client came back the next time and said, I tried it. I couldn't stutter. Because you're thinking about what you intend to do, instead of fearing it, you actually think about it. You're losing that looming monster. It's not the boogeyman under the bed anymore. You're attending to the issue, and you're actually finding a little humor in your problem rather than being afraid of it all the time. Again, it's clients exerting control over their situation. Next slide, please. De-reflection. Essentially, we think about problems way too much. Anticipatory anxiety, substance abuse. We end up creating, we think about the issue so much, we focus on the issue so much and with such intensity that it creates anxiety and it makes the problem worse. De-reflection is an attempt to reduce this anxiety by, ultimately moving your direction, moving your thoughts into a completely different direction, which ultimately will cause a reduction in the symptom of the problem itself. Next slide. And you can read the next slide at your leisure if you choose to. It's hyper-reflection and hyper-intention. Both of these are answered by de-reflection. Hyper-reflection is an over-consciousness of one's own behavior or over-attentiveness to an issue that inhibits. So this can be an issue with panic attacks, anticipatory anxiety, or triggers for substance abuse. Hyper-intention is an obsession with the outcome. I have to be clean. I can't use anymore. It can have to do with even sexual disorders. De-reflection treats those. If you'd move on, please. Logo analysis, ultimately, it's just simply, it's a better understanding of what your purpose in life is. It's more commonly referenced as purpose in life tests. If you'd skip to the next slide for me, please. I just put a few questions up there. You can review that by just simply doing a Google search, Purpose in Life Test. It's by Crumbaughh, C-R-U-M-B-A-U-G-H. And this is something you can use with your clients to kind of ascertain where they're at. And it asks questions. For example, life to me seems completely routine or always exciting. And you'll see there's 1 through 5. So they can pick, is it always completely routine? Is it midway? Or is it very exciting? If I could choose, I would prefer never to have been born, or I'd want 9 more lives just like this one. The Purpose in Life test is a great empirically validated test, which helps you understand where your client is in terms of meaning and purpose in life. Next slide, please. We're going to actually skip through the self-appraisal exercise and the value auction. It is something you could look up, but these are actually just a couple of different exercises that I recommend. But because of the time constraint, I'd like to try and answer a few questions if possible. So you could skip through that slide. You could skip through that slide as well too. I will say that psychometric assessment of meaning construct, purpose and life test, life purpose questionnaires, and the seeking of noetic goals tests. these are ample evidence for the consistency of finding purpose in life for the scores that come out of there. Coefficient alphas are typically in the 80s to the 90s, which are quite high. Next slide, please. And in summary, I'd like to just put up a quote for you guys to consider. Between stimulus and response, there's a space. Between between having the trigger for a drink and taking a drink, there's a space. Between starting to feel anxious and having a panic attack, there's a space. And in that space, it's our power to choose our response. And it's how we choose to respond. It's the choices we make in between stimulus and response. That's our growth and our freedom. It's our cure, or it's our attending to our symptoms. It's choice. Next slide, please. And ultimately, the last thing I'd like to leave you folks with is logotherapy is part of a trans-theoretical approach. No one in this day and age can say I am strictly a Freudian analyst, or I solely use cognitive behavioral therapy, or I'm a dialectic behavioral therapist. It just doesn't happen. It's trans-theoretical. What I will recommend, logotherapy is an excellent modality to be looked at in terms of long-term and short-term treatment methodologies. It can be successfully integrated into individual, group, couples, and family and crisis counseling. I think it's a great thing to have in your therapeutic toolbox, and I think it's something that everyone benefits by reading up on a little bit and possibly expanding, your clinical efficacy. I think that's the last slide. And just references. You don't want to go through that. Too many there. Are there any questions I can answer?
I'm looking at the chat. I don't see any right now, but please, we have a few minutes here before 1 o'clock. So if anyone has any questions, please type them in the chat and can make sure that we touch on them.
Okay, well, I want to thank you folks for joining me.
You know what? We have one question that came in, just popped up. It says, how young of a client could use this theory?
How young of a client could use this theory? So there have been studies done where logotherapy, age-appropriate logotherapy, has been used as young as 6 to 7 years old. Again, it has to be age appropriate. Logotherapy is tends to be a little more of a highly actualized form of therapy because you're asking people to think about meaning and purpose. However, they've found studies where with like kindergarten age, lower elementary, talking to them about, when they feel poorly about life, talking about the people that love them, what they like to do, their friends, issues like that. It helps to develop like rudimentary meaning in life. And it helps a child see that, if I'm having a difficult day, there's reasons for me not to go hide under the bed or pull the covers over my head. Life will get better. There's things that bring me joy and happiness. Interesting question.
Great, thank you. And another question, but yes, the PowerPoint will be posted to our website. We'll have both the video recording from today's session and the PowerPoint posted within the next day or two. So feel free to go on and look at that or any of our past ones as well. That looks like the question. So just wanted to take a minute to say thank you, Tim. Thanks for the great presentation.
Thank you.
And thank you for all who attended as well. Thanks, Amy, for your technical assistance and for moving slides along. I did paste the link to our evaluation in the chat. I'll paste it again right now in case it got bumped up. So we just ask that you take a minute or two to fill out that evaluation. Mark your calendars for our next session, which is July 26th. More details to come. And for future sessions, they're all the 4th Tuesday of the month from noon until 1. We'll be sending out future notices and registration information, and you can always check our website. Again, that's erie.gov/mental health. If you're interested in being a presenter or have a topic you'd be interested in, let us know. Put that on your evaluation or contact Amy. Again, thank you, Tim. It was a wonderful presentation. Thank you all for being part of our collaborative.
Thank you very much, Amy. Thank you, Kathleen. And thanks to all of you that attended. I truly appreciate it.